Hi everybody, it's Chris Morosky, and in this video I'm going to do a review of the female pelvic exam. This video is used as part of the orientation to the UCONN School of Medicine OBGYN Clerkship. So let's jump in a little bit and just talk a little bit about the pelvic exam. As I always really like to emphasize with all of my clerkship students, there are 4 parts to the female pelvic exam. There's inspection of the external genitalia, there is the speculum exam, there's the bimanual exam, and there's the rectovaginal exam, or as I like to call it, the vaginal rectal exam. Now, in this clerkship, with the 6 weeks that you're going to be with us, we are not expecting you to be expert at any of the aspects of the female pelvic exam. The design of this is to expose you to the exam, to begin to introduce you to the instruments and what the exams look like. But what we really hope that you'll gather out of this is understanding where and when and why to apply the different parts of the female pelvic exam, and to feel comfortable counseling a patient about what parts of the female pelvic exam you want to perform based on her presentation, and also which parts you may choose to leave out. And so that's probably more important than, say, being able to find the cervix for every single pap smear that you're going to do when you do a speculum exam, or feeling every single ovary on a bimanual exam. We don't do that every time ourselves in clinical practice. Nobody does. And so we don't expect you to be experts at this in the time that you're going to be with us. If you want to improve your pelvic exam skills, well, then you just need to continue to practice. And so if you go into a specialty such as OBGYN, family medicine, emergency medicine, pediatrics, where you'll have opportunities to practice exam, you'll start to get a lot better at it. Okay, so let's briefly jump a little bit into the equipment. That's one of the things that is a little bit intimidating to medical students. When you come into my office, you're going to sit down and you're going to do your first speculum exam. You're going to pull open that drawer underneath the patient, and you're going to see there's 30 speculums in there. And you're going to look at them. They're all going to be of different shapes and sizes, and you're going to say to yourself, how on earth am I supposed to prepare for this and know what to do? Well, let's go through that just a little bit and talk a little bit about the equipment, okay? So right here you can see I've got 2 speculums in my hand, and it's pretty easy to see that there's some big differences here in these speculums. This speculum is a plastic speculum, and this speculum is a metal speculum. Doctors who perform lots of pelvic exams and do lots of speculum exams, like OBGYNs, are going to preferentially use metal speculums. We can buy this once, and we can sterilize it and use it over and over and over again. In places where you'll do occasional speculum exams, like the emergency room, or even in, say, a pediatrician's office, you're probably going to see plastic speculums. The other thing that goes with speculums in my office is you need to have a light source for both, but for us we have a light source attached to the bed because we do many of these exams. For offices that don't want that expense, what they'll do is they'll buy the plastic speculum that has an area for the light to kind of go inside the speculum. The whole speculum is lit up. And that's something that actually is beneficial, seeing the whole speculum, the whole vagina lit up. But you're going to see on this rotation, primarily you're going to be using metal speculums. To go over the anatomy of the speculum, just briefly, the part that you hold on to with your hand is called the handle. That's not too surprising. And the part of the speculum that actually enters the vagina and opens are called the blades. And then you have the fulcrum right here with the little lock that kind of pushes down. It's like a little wing nut, and that's what holds the speculum open for you to do your inspection and specimen collection. What I also like to point out to students is that there is another little wing nut on the handle that you can slightly undo, and that allows you to push the aperture, the opening of the speculum up so that you get more exposure, kind of like that, and then you can lock it into place. Importantly, this part of the speculum is pushing under the urethra and clitoris, and so be very careful when you're doing this. I almost never will use this like opening part of the speculum unless I'm doing a procedure like a colposcopy or a LEEP, or I'm really not seeing things. But before you increase that right there, make sure you warn the patient that she's going to have increased pressure. The other thing you can do with this is actually you can take the wing nut completely off, and then the top part of the speculum will come off. And then you can have sort of a single-sided speculum. This is really good for patients who are presenting with prolapse. So you can place this in the posterior vagina and gently pull posteriorly, have the patient Valsalva or push, and you can see if the anterior part of the vagina is prolapsing. Then you can remove it, place it in the vagina, gently pull anteriorly, have the patient Valsalva, and then see if the bottom part of the vagina prolapses. And that's how we can differentiate a cystocele from a rectocele. Really importantly, when you take this off, before you even go doing any of that exam, put the wing nut back on and let it sit here while you're doing the exam. It's very easy for this to fall out of your hands and roll under the exam table, and then we never see it again. And then that speculum's useless. So that's just a good rule of thumb, is once you take this off, put it back on before you go doing anything else. The speculum easily goes back together. There's little tiny grooves here that kind of hook right back into the top part of the speculum. You can put the wing nut back on, and then the speculum is sturdy. Before I use the speculum every time, I take it out of the package, I inspect it, I make sure it's like nicely put together and not crossed a little. I make sure that it opens and closes, and I make sure that the lock wing nut will go down easily and stay down, and then open. It's not fun to find out with the speculum placed in the vagina during the exam that this is broken or bent, and that sometimes happens, and that it's not usable. It can be uncomfortable. That's where you start having things like pinching the patient. And it also means you're going to have to get another speculum and do a whole other speculum exam. The patient's not going to want that. So check your equipment before you use it. Looking at speculums, what you're going to see is that, yes, in fact, they do come in different shapes and sizes. What's important for everybody to realize and remember, and I don't think this is always known, is that vaginas come in different shapes and sizes. And that makes sense. I mean, penises come in different shapes and sizes, and we all know that. So why wouldn't vaginas come in different shapes and sizes? And they do. And so we have speculums to accommodate a different shape and size to the vagina. Now, before we talk about the speculums, in selection, there are certain life occurrences that happen to women that change the shape and size of the vagina. So for young adolescent women or girls and postmenopausal women who aren't making a lot of estrogen, they will tend to have smaller vaginas. Women who are menstruating regularly and sort of in their reproductive years will tend to have longer vaginas or wider vaginas. And other things that will change the shape of the vagina is childbirth, and specifically vaginal birth compared to cesarean section, and whether or not women are having sex in the vagina. And so those are the things that are going to make you choose the size of your speculum based on just taking good history. So a woman who is, say, 32 years old, having sex in the vagina, and had 2 prior vaginal deliveries, that's a patient that you're going to use a slightly wider or longer speculum than a patient who, say, is 59 years old, never had any babies, and is not having sex in the vagina. That's a patient that you're going to default to and pick a smaller speculum. I'm holding up 2 different types of speculums here, and if you take a real good close look, you can see that this speculum is more narrow. It's just wider than the width of my finger. And then this speculum over here is more wide. It's about the width of 2 of my fingers, all right? This more narrow speculum is called a Peterson speculum, and this wider speculum is called a Graves speculum, all right? So again, I use Graves speculums preferentially for women in their reproductive years who've had vaginal deliveries and are having sex in the vagina, and I'll use Peterson speculums, again, for patients who may not have all 3 of those characteristics. You can also see that these speculums come in different lengths, and we're going to talk a little bit about the length of the vagina when we talk about the speculum exam. But also, these come in different sizes. So these are kind of the medium versions of the Peterson and the Graves. With our plastic speculums, you can see right here, this is a medium Peterson, and then this is a large Peterson. So this can get even larger. There's small and extra large versions. Then there's also our pediatric speculum, which is very small. And then even make an extra large version of the Peterson speculum that's quite long and large. And to be honest, there are some patients who do need that larger speculum to be able to see all of the vagina and the cervix. For those patients that need sort of the extremes of the speculums, either very small or very large, I usually will share that with them during the visit and remind them to remind me that they need that special speculum. And that just helps them kind of avoid 2 or 3 speculum exams until we find the cervix. So that's a good thing to note in the chart. And that's also something that I point out to patients because I think it's good for people to know about their bodies just in general. But it also helps me and her the next time I have to do the exam. So that's speculums kind of 101. The other thing I wanted to cover very quickly are the different devices that you're going to see for us to acquire our pap smear. So when you're doing a pap smear, you're really trying to just exfoliate some of the cells off of the ectocervix and some of the endocervix. And the goal really is to be exfoliating the transformation zone. That's where most of the cervical dysplasia is going to be. So you need to be seeing the whole cervix sort of pointing at you with the transformation zone. And then you've got sort of 3 options for ways to acquire exfoliated cells from the cervix. The first traditional one is the pap spatula. So here's the spatula up close. It has the end where we'll acquire the cells, and it has this other little end for a handle. To be honest, this end is good for patients for either vaginal pap smears, which is rare, but we do it, or for patients with very small vaginas and you don't have a whole lot of room to get the whole spatula down the speculum. But for the majority of your patients, this long arm of the spatula is going to go into the opening of the cervix, and then this sort of trailing part is going to be what's exfoliating the transformation zone. And it's going to look a little something like this with application. If that's the cervix, you're going to put it in here, and you're going to exfoliate this way and that way. It is possible not to acquire enough cells, and patients don't like having to come back with an insufficient sample. So you don't want to spend a lot of time with this, and you don't want to be scraping until patients are having a lot of bleeding. But I usually will do 1 or 2 turns clockwise and 1 or 2 turns counterclockwise just to make sure that I've acquired enough cells for the pap smear. So that's the pap spatula. If you use the spatula, commonly you would then use what's called the cyto brush. The cyto brush goes into the endocervix and is going to acquire some of the columnar cells of the endocervix. And so that's going to look like this, and it's going to go inside. You want to go until the bristles sort of disappear out of sight. And again, I turn 1 or 2 times clockwise, 1 or 2 times counterclockwise, a little in and out as I spin, and then remove it. Again, you want enough cells. Last but not least, there's the cervical broom. There's 2 versions of this. This has the green handle. The green handle has both these little brush bristles that will acquire cells from the ectocervix on the outside, and this slightly more firm part of the broom that will go into the endocervix. And so you can see that you can place this and get the endocervical and ectocervical cells at the same time. There's another broom that has just the purple handle, and it doesn't have this tip on it for the endocervical cells. To be honest with you, I prefer that one. I find that this part is a little bit rigid and hard to get into the cervix and also uncomfortable. So Chris Morosky prefers to use either the pap spatula with the endocervical brush or the broom with the endocervical brush. And to be honest with you, I really don't like insufficient samples. You guys will get to know that if you work with me. And I do all 3. I use the pap spatula, the broom, and then the endocervical brush. And it's gentle and it's quick, but I really try to prevent inadequate specimens. Okay, so that is a review of some of the equipment. The other equipment to know about is we do have a small Q-tip, a special container to screen just for gonorrhea and chlamydia. That's just a Dacron Q-tip that goes into the endocervix and is left there for some time. And then also we have just longer Q-tips which we'll use to acquire specimens for wet mounts, for vaginitis. And last but not least, we have this new nucleic acid amplification test for other vaginal pathogens that looks for overgrowth of yeast, bacteria, Gardnerella vaginalis, and for trichomonas. And so that's another swab that you have. That's a swab with the vagina. So I don't have those here today, but those look just pretty much like Q-tips. And we'll show you like when those are indicated. Do know also you can run a nucleic acid amplification test off of your pap fluid. And so if you're collecting a pap smear and you want to check for gonorrhea and chlamydia, you don't need a separate swab anymore. Okay, so let's now talk about the specific parts of the pelvic exam. As I had mentioned earlier, the first part of the pelvic exam is inspection of the external genitalia. For the gynecologist, the area that we're going to want to inspect that, say, internal medicine doctors, primary care physicians aren't going to really do a thorough job of examining or examine at all and leave that sort of for the gynecologist, starts at the mons pubis anteriorly and ends sort of just at the anus and the buttocks posteriorly. And we're also going to be looking in between both thighs at the external genitalia. So this inspection doesn't have to be very long, but this is something that almost should be performed on every single patient every single time. Patients don't commonly inspect their vulva and genitalia a lot. It can be difficult to see. There can be various different skin changes, growths, and lesions that are really important for the gynecologist to pick up on. So if you're doing a pelvic exam, I usually recommend that this is done briefly. What it looks like is you're just going to want to inspect the mons pubis. There is some mention about palpating the inguinal lymph nodes, even though that is getting a little bit out of the genitalia, but it is part of the pelvic exam. And then you're going to look in between each intracrural fold. And so that's the space between the thigh and the labia majora. You do that on both sides. And then you're going to want to take some time to inspect the perineum, the anus, and make sure there's not any hemorrhoids or skin changes down towards the buttock. At this point then, you're going to want to separate the labia majora and minora gently on both sides to see the skin in between the labia majora and minora. And then you're going to let the patient know that you're going to gently touch the vagina and separate to look anteriorly at the urethra and the clitoris, as well as posteriorly at the posterior fourchette, and again inspect the perineum. We sometimes will palpate for the Bartholin's glands, particularly if patients are complaining of swelling there. What that looks like is you put a little bit of gel on your finger and you just place one finger up to kind of the first knuckle in the vagina, and you're going to feel over gently at 7 and 8 o'clock for the right Bartholin's gland, and over to the left side at sort of 4 and 5 o'clock and palpate for the left Bartholin's gland. Up under the urethra are also lubricating glands called Skeen's glands. To feel for those, again, gel on the finger, place the finger just up to your first knuckle into the vagina, and then gently push anteriorly off to say 10, 11 o'clock to feel the right Skeen's gland, and then off to about 1 or 2 o'clock to feel the left Skeen's gland. Skeen's glands are very small and you're probably not going to feel them. So that's a brief review of the inspection of the external genitalia. Honestly, that can be performed in about 10 to 20 minutes. If you do any skin changes or lesions, that's a good time to ask the patient if she's noticed that, if it's been there persistently, if something is bothering her. So next we're going to move on to the speculum exam. So I do the speculum exam next. For this patient, we're going to select our medium Peterson speculum. What I like to do for this is let the patient know that we're about to move on to the speculum exam. And then I'm going to put some gel in the speculum. Now you don't want to cover the speculum with a whole lot of gel because it can interfere with the pathologist's ability to read some of the specimens or your DNA tests. And so just a little thin coating of our lubricant anteriorly and definitely posteriorly will help the speculum slide into the vagina. One thing that's important for medical students who are doing this for the first time, you might get nervous, is you want to hold the speculum in between your index and middle finger like this. The reason is if you're a little nervous and you have a tremor, that's going to be okay. If you hold it sort of like this, the patient's going to hear that, and that's going to make her very nervous, okay? So get in the habit of holding kind of right here. Also, this stabilizes the speculum very well. When you're placing the speculum in the vagina, patients are really expecting that the speculum is going to go into the vagina. You actually have 4 places that you could place the speculum, and 3 of the 4 are wrong. You don't want to place the speculum into the clitoris. You don't want to place the speculum into the urethra. You don't want to place the speculum into the anus. And so the best thing to do is make sure to look the speculum into the vagina, which is where you want it to go. So to do that, I recommend either come up over the top with your non-dominant hands to spread the labia majora minora and look into the vagina, or underneath posteriorly, again, to spread the labia majora minora so you can see into the vagina and exactly where you want to place your speculum. So for me, I usually do this sort of like anterior to posterior over the top, separate the labia majora minora, I can see the introitus. I usually tilt my speculum about 45 degrees. You'll see some doctors will tilt it 90 degrees, some doctors will place it straight. Everybody's very passionate about that. Just do whatever your resident or attending tells you. There's no right answer. But you want to, most importantly though, look the speculum into the introitus. Once you've gone in about 2 or 3 centimeters, you can then rotate the speculum to the anterior and posterior. That's how you want it to be in the vagina for most of the exam. You can move your non-dominant hand away. At this point, you want to raise the speculum gently superiorly and then gently place the speculum all the way into the vagina. All right, now, one of the things that medical students do that gets you guys even more nervous and actually makes the patients uncomfortable is you'll place the speculum in the vagina not too far and start to open it. There's 2 problems with that. The average length of the vagina is about 10 centimeters. This speculum is actually only about 8 to 9 centimeters. And so you do need to place the whole speculum in the vagina to get to the back of it where the cervix is. The other thing that's important is that the outer part of the vagina has somatic intervention, and that's pinchy and painful. The upper 2/3 of the vagina has visceral innervation, and sort of that is less uncomfortable or feels more like pressure than pinching and hurting than the outer part of the vagina. So, one of the errors I see is you place the speculum only part way into the vagina, think you're being kind, start to try to open it too soon, you won't see the cervix, and in fact you're going to start causing the patient more discomfort than if you actually place the whole speculum into the vagina first and then started opening the speculum. Okay? Hopefully that's very helpful to you. So what we're going to do here, again, back to our speculum that we've placed by looking it in. Now we're going to raise, we're going to look posteriorly. Once the majority of the blades are into the vagina, then you're going to slowly start to open the speculum until the cervix comes into view. Now I know on the video you can't see all the way down the cervix because there's no appropriate lighting here, but I do have the cervix in view and it looks like sort of like a donut hole. For patients who have never had vaginal deliveries, the cervix will have a circular opening. For patients who've had vaginal deliveries, it'll be a slit-like opening. For patients who've never been pregnant, or sometimes with C-sections, the cervix will be very small, like the size of my finger. And for patients who have vaginal deliveries, they can have a cervix that's very parous or large. All right, so the cervix really can change with pregnancy and childbirth. I usually recommend kind of having one hand on the speculum and getting your assistant to hand you your swabs and different things, but through the speculum, you're going to see the spatula down to the cervix. Again, you rotate 1 or 2 times one direction, 1 or 2 times the other direction. That's going to go in the PAP container. Here's my cyto brush. That's going to go all the way through the endocervix, 1 or 2 times in one direction, 1 or 2 times in the other direction. And you're going to take that out in the container. And last but not least, if you're using the broom, that's going to go down the speculum to the cervix, all through the endocervix, 1 or 2 times in one direction, 1 or 2 times in the other direction. We're going to have you guys practice this sort of twisting in the sim center when you come for orientation. It's not a hard thing to do, but it's sort of like chopsticks. You do need to practice it a little bit. So we're going to have you guys practice doing that. Once you've required all of your specimens, and even before, you want to have taken a real good look at the cervix. You're going to inspect the vaginal side walls and the rest of the vagina, and you're definitely going to want to look at the vagina as you remove the speculum. Now, when you remove the speculum, you want to, again, hold the fulcrum and release the lock. I release it all the way, but you don't want to let the speculum close too quickly. That's going to kind of click right off the cervix, and that's going to be uncomfortable. So what I do is I actually pull the speculum out just about 1 centimeter or 2. The cervix will fall away, and then at that point I make sure I'm all unlocked, and I'll start to let the speculum close as I remove it, and with my non-dominant hand, again, I'm separating the labia majora minora as I take the speculum out. All right, and as you're removing it, you want to be looking at the vaginal side walls to make sure that you're not missing any vaginal lacerations, or if they're bleeding, or lesions, or anything that needs to be seen. So that's the speculum exam. You'll then place the speculum either in a little bucket, depending on the office, or we just put ours in a little carton because that's how we got to do things around here. Okay, moving now on to the bimanual exam. So for the bimanual exam, if you were seated for the speculum exam, you need to stand up because you're going to need to generate a little bit of force and pressure to be able to feel the uterus, tubes, and ovaries. So for this, I tell the patient, I'm going to now move on to the bimanual exam. I'm going to gently just put some gel on my 2 fingers. And what you're first going to feel is I'm going to place 2 fingers in the vagina. So again, you want to place your fingers in the vagina because the patient is expecting it to be there, so you're going to want to see your fingers go into the vagina. So I tell the patient you feel a gentle touch on the outside of the vagina with my fingers, a little cold touch with some gel, and some pressure as I place my fingers into the vagina. And again, you want to go posteriorly, okay? The cervix is posteriorly when women are in the lithotomy position. Also, the rectum is designed to distend and contract with stool, and so there's not a lot of pain and discomfort there. The urethra and the clitoris are uncomfortable, so avoid being anterior. Once you feel all the way down to the vagina, you're going to feel the cervix is much firmer. If the patient's having any type of pain, I usually will pause here and just say, okay, I'm palpating or touching your cervix right now. I'm going to gently move my fingers side to side, just like that much, and I'll ask if that hurts. True cervical motion tenderness with like salpingitis or PID, that little bit of movement is going to cause significant tenderness, okay? You don't really need to like push very briskly to get cervical motion tenderness. If it's not tender, I say, okay, now I'm going to feel for your uterus. And so I gently just push, and you know, we teach you to start here up at the umbilicus, but as you get down towards the pelvis, you're going to want to support the cervix and gently compress the outside hand towards the inside hand, and you should feel the cervix, the uterus, in between your 2 fingers. And so this is a sort of slightly enlarged uterus that this patient has right here, because I'm feeling it just above the pubic bone. All right, the uterus you should be able to feel unless the patient has an axial, straight, or retroverted uterus. Most women have an inverted uterus, and you should be able to feel sort of that there's something in between your 2 fingers. All right, after that, what I do is, I was holding the cervix the whole time. I come off the cervix and go to the lateral fourchette. All right, so I'm going to feel for the right ovary here by coming off the cervix, feeling off to the right, and I tell the patient you're going to feel some gentle pressure as I start to work my way down, feeling for the ovary and any adnexal masses, again, trying to compress that ovary, if there were an ovarian cyst, in between my 2 fingers. And I'll ask again, are you having inner tenderness? And then I repeat it by moving my hand to the left lateral fourchette, and I begin to work my way down, again, as I'm gently pushing in with my internal fingers and trying to meet my external internal fingers with feeling the ovary in between. Okay? And that's how you do the bimanual exam. Sometimes that's where we'll do the palpation of the glands, but we tend to do that also with inspection of the genitalia. Last but not least, the rectovaginal exam. I tend to change my gloves, put new gloves on. If you're going to do the fecal occult blood, you definitely need to change your blood, your gloves. If you've picked up any blood, say from the pap smear, and then did your bimanual exam, and then you do the fecal occult blood card, it's going to be positive, and that's going to be concerning. So I get new gloves. I put gel on my 2 fingers again, and I let the patient know that we're going to do the vaginal rectal exam. And I will have talked to her ahead of time about why we're going to do that. I call it the vaginal rectal exam because, again, patients want to be prepared for things, and you're going to actually place your vaginal finger first before your rectal finger. So I let the patient kind of know that so that they kind of know what's coming and they're not concerned. I don't know the difference between the vagina and the rectum. So with this, I let the patient know, again, you're going to feel a touch on the outside, then you're going to feel 1 finger gently placed into the vagina, so gel here, into the vagina, and now you're going to feel a 2nd finger into the rectum on the count of 3. 1, 2, 3, a lot of pressure. All right? And so now you have your 2 fingers around the rectovaginal septum. You want to gently move them side to side, and you're going to try to just feel the tissue in between. All right? And you're making sure that there's not any nodularities there. All right, so back to my vaginal rectal exam. You're just kind of gently feeling to see if there's any nodularity or masses there. And then what I'll do is I'll often repeat the bimanual exam with my attention on my rectal finger as I'm feeling into the cul-de-sac of Douglas and along the uterosacral ligaments. Again, any pelvic pain or masses in the adnexa, I'll confirm that with a rectal exam, with a rectal finger. And then last but not least, when I'm done with the palpation, I'll remove my vaginal finger and I'll just sweep around the rectum and do a gentle rectal exam. And again, you're just trying to palpate if there's any rectoceles. That's one way we can confirm that with the rectal finger. If there's any masses in the rectum, if there's any pain in the rectum. All right, and then I remove my finger. Again, if you're using a fecal occult card, you'll have that set up. You'll put some of the specimen there, close it, and then have your assistant put the developer on it. When you're done with the pelvic exam, you're going to want to assist the patient into the recovery position, or help her sit up and get out of the stirrups. You're also going to want to offer her a towel or a tissue to wipe up any gel that might be left behind. And then if there's any bleeding, or just with every patient, you can offer them a pad to take home. We usually have those in the cabinet. Also important is to review the pelvic exam findings with the patient. I will commonly say to patients, the outside of the vagina and the inside of the vagina looked healthy and normal. Your uterus, tubes, and ovaries palpated normal. I didn't feel any masses. There was no tenderness there. Your rectal vaginal exam was also normal. Practice the word normal. The word good is a little bit not the best word to choose for this. Things like your vagina feels good, or everything is really good, just doesn't sit well. It's really not appropriate. So practice the habit of normal. If you do see something that's abnormal or palpate something that's abnormal on exam, let us know if we haven't picked up on that. I usually like to include patients as we're discovering things. So if I see something on the vulva, I'll immediately start asking her about it and get some quick follow-up information. If I see something on the cervix, or if I palpate something in the adnexa or uterine mass, I might just ask some brief questions about, has she noticed this before? Is this something that's been documented before? So that's a good thing to get in the habit with the patients. I always thank patients for letting you be involved in their care. I know that this is a sensitive exam, and I really appreciate them helping to teach you to learn these exam skills. My last point, and I've brought this up before in orientation, but just make sure that for these exams that you are doing them with us, and that we have a chaperone. Not just ideally, but you must really meet the patient ahead of time, introduce yourself, explain that you're a medical student, part of the team, tell her that you're going to be part of her care today, ask her if it's okay to perform the parts of the pelvic and or breast exam. We'll go over that differently during her visit today, and let them know that you will be directly supervised by me or one of my residents. And then she'll have the opportunity to consent for your involvement in her pelvic exam. That's really important. And just to touch on the idea of chaperones, I always have a chaperone. Male, female medical students doesn't really matter to me. I always have a chaperone, and mostly because our medical assistants have very important roles in terms of patient safety with doing timeouts and labeling specimens, getting us extra instruments if we run into an unexpected finding. And so I recommend that as best practice. Okay, I hope this video provides you with a good overview of the female pelvic exam. I hope you're feeling a little bit more confident about doing it as you come on rotation. Again, our expectation is not that you're going to be expert at this, but what I do hope is that you understand the 4 parts of the pelvic exam, where, when, and why we'll choose to do those, and how we counsel patients around performing the pelvic exam, how to actually do it, and then how to relay the findings. Okay, good luck with the rotation. We look forward to seeing you soon. Bye-bye.